So when you look at this topic, what do you feel? Like it's about lipids. As he correctly mentioned, when I was a medical student, even a PG trainee, the term lipids is very confusing and always would like to kind of skip or go away from that with superficial things that we could do. But my interest diverted to lipids when I went for my overseas training, because I was amazed to see that this lipidology is having a separate entity with very much evolved lipid management service in the European and rest of the world. In fact, they have separate lipid clinics, lipid services, lipid research centers, and I was fortunate enough to be full-time trainee for 2 years under pioneers in lipid management, which have inspired me to think about this topic in our setup. I was wondering whether are we doing it enough. So not only this is a map of lipid network where all the general practitioners in UK, they are networked into lipid management centers, which also we might be doing to some extent, but I think what we miss is this networking, as well as there are guidelines, there are pathways, but I wonder whether we are really following these and assessing those and trying to see what we really can achieve. Okay, so I will do some case-based discussion, and I would be glad if you can respond to some of the questions or your opinions while we are going through the cases, so it will be more interactive. So the first patient, 55-year-old male, presenting with following a routine medical checkup, coming with this lipid profile. So what can you see here? What can you see here? What is the abnormalities, the striking abnormality you see here? Yeah, I can hear triglycerides, somebody mentioning, and total cholesterol, and anything else? HbA1c, yes. So there are many things. Okay, so how about the LDL cholesterol? Do you have any idea why it is not here? Yeah, we'll talk about it. So before that, we'll see, like when you get this lipid profile, from a layperson point of view or any beginner in the medical career, you will be confused with a lot of terms. What is this LDL, VLDL, there is triglyceride, what is cholesterol? So to simplify it, I just we'll go through some basics. We know the triglycerides and cholesterol, they are the basic lipids in our body. They are not soluble in water or in blood. So they need some kind of a transporter to be carried throughout our body. So these transporters are serving like vehicles. They are lipoproteins. So the lipoproteins are actually proteins plus lipids, as the name implies. So you can see a lipoprotein molecule where there is, in the center, there is hydrophobic core, where you have triglyceride and esterified cholesterol, covered by hydrophilic outer layer. So these are the types, and there are different densities, different molecular weights, and this the protein molecules, not only they transport the lipids, they act as receptors at different tissues to help in metabolizing these lipids inside here. So when you refer to a book or when you read an article, you will encounter various things. There are lipoproteins, there are apoproteins. So you can see there are different apoproteins, A, B, C, D, E, and this ApoB present in several lipoprotein particles, VLDL, IDL, LDL. They are considered to be highly atherogenic particles. So that's why you might have heard some of the PG trainees are here. You can measure this apoprotein beam to check the atherogenicity, which is evolving in the field of lipidology. Okay. All right. So how about what happens to the lipids or triglycerides in our body? How do they come to our body? So there are mainly two pathways. Some say three pathways, but we can simplify it as exogenous pathway and an endogenous pathway. Exogenous means that the lipids are coming from outside. From the diet that we eat, they are digested, and via lymphatics, they are incorporated as chylomicrons, where there is more triglyceride more than cholesterol esters, and they go through the body, bypass liver, through the lymphatics, they go through the liver. In the periphery, they undergo metabolism via lipoprotein lipase, where they release this triglyceride and release free fatty acids. So now the triglyceride content has reduced and they become chylomicron remnant and they go into liver cholesterol pool. So this liver cholesterol pool has different endpoints. So one is part of it can be stored in liver and they can be excreted as cholesterol, and some go into produce bile acids as well. And the other important pathway, you can see our dietary lipids, they can enter into our endogenous pathway where they can induce endogenous production of lipids. So the endogenous pathway, where how the lipids or triglycerides and cholesterol are produced in our body, mainly the cholesterol. So from the medical student days, you might remember the rate limiting step here, acetyl CoA produce cholesterol. This is a rate limiting step where the statin act, and ultimately this cholesterol have again various endpoints. So one is production of VLDL produced from liver. There is still little more triglyceride than cholesterol esters, and at the periphery, under lipoprotein lipase enzyme activity, they release this triglyceride and go into tissues, and they become LDL. And another particle missing here. There are ideal intermediate density lipoprotein particles which are highly heterogenic. So apart from that, this after that, this LDL particle and ideal particle, they are uptaken from the liver via the LDL receptors. So this pathway is important to understand because the drugs are acting at various levels of this lipoprotein or lipid metabolism pathway. Liver also produces high density lipoprotein, which is known as a good cholesterol. Why? Because it is known to get cholesterol from the periphery into HDL molecule and transfer within other lipoproteins. So we call it reverse cholesterol transport as well. So this is kind of a simplified way. The actual pathway is much more complex. Just to understand what are these types when you see the lipid profile, what are these types, what happen basically in the lipoprotein and lipid metabolism in the body. So when we get the lipid profile, when you look at the figures, the total cholesterol, HDL cholesterol and triglycerides, they are generally direct assays. We can measure them directly, direct measurements. But LDL is mostly, it is a indirect use. Most labs, even in the western part of the world, it's by indirect calculation. By what is this called Figward formula. In our setup, which is milligrams per deciliter, the reports that we commonly see. How do you calculate that? You can reduce HDL cholesterol from total cholesterol. From that, you can reduce the triglyceride divided by 5. So it will get the LDL cholesterol in milligrams per deciliter. Okay, so there's a problem with calculation of this method. This method to calculate the LDL cholesterol, this formula is invalid when the triglyceride level goes up. So you might have seen this non-HDL cholesterol which appear in the lipid profiles as well as a lot of risk calculators, because most of the time we can calculate it very easily. Okay, so generally this non-HDL cholesterol target is about 30 milligrams per deciliter. Additional, maybe it is a target or a goal to LDL cholesterol. So it's easy to work out if you follow most of the guidelines regarding the recommendations and target reductions. Okay, so can I ask a question? So if you are asked to do a lipid profile, the same patient that presenter that we discussed, 65 or 55 years old patient, previously healthy, coming to you Are you going to do a fasting lipid profile or a non-fasting lipid profile? Can I see the hands up who say I will do a fasting lipid profile? Good, that's a good number. And non-fasting lipid profile? Okay, so I can see some not giving a clear answer as well. Okay, let's see. So this is EA, European Atherosclerosis Society guidelines. This came in, I think, 2016. They suggested fasting is not routinely required. So this evidence is mainly coming from population screening and for moderate risk individuals for primary prevention, because they, in those countries, they are targeting the population screening and looking at the cost-effective way of looking at problems, cost-effective way of catching problems. So if you have, theoretically we know that the dietary or non-fasting status can increase all the lipid parameters up. So if we do a non-fasting one, random one, it's high chance that you can catch the extreme points. That may be the reason, not very clear, but that led to several recommendations from went into the guidelines as well, because the change that they measured between fasting and non-fasting from the studies available, they were not statistically significant. But there are studies like mainly cross-sectional and follow-up studies showing this. There are differences between LDL cholesterol and triglycerides when comparing fasting and non-fasting state. So now the current recommendations, so if you look at current reviews or guidelines, it recommends doing a fasting lipid profile if you do a non-fasting one and triglyceride is high, and selected individualized targeted assessment with high risk individuals and or established cardiovascular disease. And when you are going to check the lipid profile, whether you are getting the lipid levels accurately, because on treatment we need to, like, generally we look at the numbers as well. Okay, so what is next? The important thing is not just treating high triglyceride. We must look at the etiology. Why this patient has this problem? So if we try to look at this patient, you might remember, had the triglyceride around 1000. The first thing comes to your mind, is it primary or secondary? What do you think? Who says primary? Primary means mostly initially known as genetic conditions for hypertriglyceridemia. Who thinks that is likely to be primary when the triglycerides are 1000? Okay, and how about secondary causes? Yeah, okay. So I think commonest cause for triglyceridemia alone, let alone the level of triglyceride, the commonest cause is secondary. Secondary means not due to a primary genetic mutation, or like either monogenic or a polygenic. We'll come into that. Medical conditions are the commonest causes that we need to actively look at. We know the metabolic syndrome, obesity, diabetes, and liver renal diseases. They can cause derangement in the lipid profile. Inflammatory diseases, hypothyroidism, TSH, and clinically they might not give the best clinical presentation that you see classically in the textbook, but they can come with this abnormal investigation findings. And there are other conditions that you need to look at, whether this abnormal lipid profile due to any medical condition. The other thing, most important thing, is the lifestyle. Whether they are having, what kind of a diet they are having. If we ask, are you eating well with fruits and vegetables? Most will say yes. But if you try to ask, what did you eat yesterday? What was your lunch? What was your breakfast? And did you eat anything in between? You will find enough causes for your abnormal lipid profile. It's very common. And then not to forget the drugs, because these drugs can have various derangements in lipid profile. Some increase the triglycerides, some increase the cholesterol as well. Okay, so if I ask to ask a student or a PGA trainee tell me about the classification of dyslipidemia. This is the classic, that our favorite Fredrickson classification that came in 1965, actually, a long time ago. They classify different phenotypes with the phenotypical appearance, that means clinical features with different lipoprotein derangements, ultimately giving rise to different levels of triglycerides and cholesterol. Initially, these were thought to be actually monogenic, which means due to a single genetic mutation, but most found out to be polygenic as well. Polygenic means, I hope you know understand the term monogenic, which means there's a single nucleotide polymorphism or single genetic mutation uh, giving rise to alterations which can be transmitted directly to the next generation. The polygenic means it's not one gene, there are multiple genes which can change the lipid profile. Some can increase, some genes can suppress the LDL cholesterol or the triglycerides. So if we try to look at the whole genome, there can be multiple genetic variants. We call them variants, not mutations, differences within a population, which can increase the risk of developing high cholesterol. So there are risk scoring available, particularly in the Western setup. They look at if the monogenic mutation is not there, they have tried to find out whether this is a polygenic. It's very common, even though we don't do it in our setup. They were found to be not due to just one mutation, due to multiple genetic mutations. So I came across this nice review article. I think PG trainees here, I will give the reference at the end. It's a very easy way, I think very comprehensive way to look at the lipids, because it may be confusing to remember which clinical feature matters with which triglyceride level and cholesterol. So first, when we look at the severe elevation, LDL cholesterol more than 94 is considered as severe, 194 is considered as severe elevation, whereas triglyceride above 100, 885, some say it's around 1000. And etiology, if you read this, it's monogenic disorder and or marked polygenic predisposition plus secondary causes. So it's not isolated genetic problem. It's always with a lot of other factors. And if you look at the mild to moderate elevation, it's usually the polygenic. That means there are multiple reasons. The lifestyle, they are on genetic makeup, environmental factors, a lot of things come into play to increase the lipid levels, triglycerides or LDL to moderate levels. Okay, so the primary levels, when we look back at our patient who had high triglyceride, I tried to kind of give a list with high triglyceride causes for high triglycerides apart from the secondary causes, the primary causes. There are different terminology where you can get isolated hypertriglyceridemia, which is common, about 10% commoner than we thought. But it's again, you can see it's polygenic plus lifestyle factors. If you think about doing a genetic testing, this isolated hypertriglyceridemia with single genetic mutation, it's very, very, very rare. But it could be a polygenic mutation. So looking at the family history, this polygenic mutation also, you can see a pattern of more elevated triglyceride within the family, because if you look at 10 genes, at least part of those genes can be present in siblings or parents. So you can get an idea by looking at the family history as well, even in polygenic conditions. And there is one thing called familial combined hyperlipidemia. It is also common, where you get high triglycerides and high total cholesterol, and they have commonly have type 2 diabetes. And this type 3 hyperlipidemia, it's a rare genetic mutation where you get elevated levels of triglycerides and LDL both. And chylomicronemia, the classic presentation you learn where you get the milky serum, where the lab returns their lipid profile or lab sample telling that we can't assess it's milky serum. It's mainly seen with very, very high triglyceride levels seen in chylomicronemia, which is very rare. And lipodystrophy syndromes, that also you need to think about when you get this presentation, apart from the primary or the common secondary causes. Okay, so are you going to treat or not? The triglycerides were thousands, HbA1c was elevated, previously healthy. What are you going to do? So the treatment goal depends on, when you look at the lipid profile, depends on several things. One is which parameter is elevated, whether it is triglyceride, primary concern, and if it is triglyceride, what is the level? And if it is not triglyceride, are there any other lipid derangement? Then you need to go ahead those lines to decide on what is your goal. What is the primary goal? What is your secondary goal? So in hypertriglyceridemia, where the triglycerides are about 1000, your primary goal is to reduce the pancreatitis, because there is evidence that when the triglyceride goes above 1000, there is at least twofold rise in risk of pancreatitis, which can go up with rising triglyceride level. So different guidelines give different cutoffs. Sometimes they recommend to look at start triglyceride lowering therapy at the range 500, but definitely at 1000. Then how about CV cardiovascular risk reduction? Because it's kind of a hot topic when you have high triglyceride and not very high level, but do you consider cardiovascular triglyceride as a cardiovascular risk? So can I see anybody who says that triglyceride elevation is a cardiovascular risk factor? Yeah, okay. Yes, like initially it was mainly concentrated around this risk of pancreatitis, but I don't know whether you can see it clearly, but if I will go through two graphs. So the lower one is about the LDL cholesterol reduction, and this y-axis is reduction of cardiovascular events. So this way, reduction in LDL cholesterol, and the black squares you see are the statin trials. So you can see with the statin trials, with the degree of reduction in the LDL cholesterol level, you can significantly reduce the cardiovascular risk. It is proven, and we are practicing. It's well evident over many, many years. But if you look at the triglycerides, with reduction in triglyceride levels, again x-axis shows the reduction in triglyceride level, and x-axis shows from the baseline reduction of cardiovascular events. So this risk reduction effect is not very well apparent with triglyceride reduction, and most of this line, the hard line, is driven by this single study. Reduce it. That's one trial which studied about I will go into it, or omega-3 fatty fish oil, what we call as fish oil, not fish oil, omega-3 fatty acids, reduction in cardiovascular events. So that has drawn this line downwards. Otherwise, the effect is not very significant, but I think the evidence is evolving. We may hear different things in times to come. Okay, so the summary is the efficacy of cardiovascular risk reduction is not very strong as LDL cholesterol reduction, because there are so many confounders and we need more data to put into practice. Whether you are going to start a fibrate in a patient who has a cardiovascular risk. That is a simple answer. Who is having elevated cardiovascular risk. Okay, so what is the treatment approach in your clinic? Now you got the patient. So I can't stress enough about these non-pharmacological measures. Almost always you can go on cycles with these, and every day you can find a lot of factors here that contribute to high triglyceride levels. The dietary changes, weight loss, they are significant factors that will reduce the triglyceride levels, and these effects can be seen very, very acutely as well. Within a couple of days, with dietary restriction, very low fat diet, you can get down your triglyceride levels. And then at the same time, we need to look at the secondary factors that we saw, whether the patient is having diabetes, hypothyroidism, renal impairment. While addressing the non-pharmacological measures, then you have to look at parallelly whether they are having any other treatable causes. Then what I'm going to do depends, mainly many guidelines depends on the level of triglycerides, whether it is about 1000, in between 1000 to 500, or between like mildly elevated, mild, moderate, severe elevation. So if the triglycerides are above 1000, we know the risk of pancreatitis is very high. All the things usually go in parallel. So strict low-fat diet, we get the help of our nutrition, the clinical nutritionist, to have a very low-fat diet, and at the same time consider starting fibrate and maybe adding omega-3 fatty acid with EPA. So you can monitor within 3-4 days to see how fast it is coming down, and maybe you can consider, if available, whether this could be a monogenic. But I put it with a question mark at the end due to many reasons that we discussed. Then how about the intermediate level? Again, you need to readdress the lifestyle factors and consider statins. As I said, this 500 and 1000 is not hard and fast guideline. Some recommend at 500 you need to start, but I would say most of the time you can find lifestyle factor that will correct this triglyceride level. But if the patient is having a history of pancreatitis or high risk of abdominal pain or having increased, like still under investigation for abdominal pain or something, you might need to consider to have a low threshold to start on fibrate. And how about this, the one that we discussed, the triglyceride might be elevated, and then because of this potential cardiovascular risk, you can assess the cardiovascular risk and you may consider, I want to highlight, may consider adding EPA, that is a form of omega-3 fatty acid, which has in one trial has shown reduction in cardiovascular event. Once you achieve the LDL target, but still the triglycerides are borderline, you can consider adding a fibrate on top of statin. But you must always remember or like think about the risk of myositis, because when you add two lipid-lowering drugs, mainly statin and fibrate, the myositis risk go up very, very significantly. So the lipid-lowering, the triglyceride-lowering medications, degree of reduction, you can see the fibrate is having greatest reduction, but just think about the cardiovascular risk and statin that also has some reduction in triglyceride level. Okay, so this one I just wanted to put here with regards to DHA and EPA, eicosapentaenoic acid, which is a type of omega-3 fatty acid, which is one of the drugs that has been subject to a lot of debate with regards to cardiovascular risk reduction. So this first one is about triglyceride reduction. This one is about the LDL cholesterol reduction. If you see, triglyceride reduction can be seen at a lower dose compared to the doses that we need to achieve the LDL cholesterol reduction. So still have been helpful in reducing triglycerides. So what happened to our patient? Actually, this patient was newly diagnosed diabetes, and 1 week previous, you could see the triglyceride have come down significantly with oral and insulin, basal insulin treatment. And so it can significantly, like looking at the risk factor and addressing it will, with all the non-pharmacological measures, will be the first step in triglyceride management. Okay, so the second patient, type 2 diabetes lady, a lady with type 2 diabetes presented following with this lipid profile. So what is the concerning thing here? Yeah, so the LDL cholesterol is high, but despite the lipid profile, she's a type 2 diabetic patient with type 2 diabetes. We are looking at cardiovascular risk reduction. I think you all aware that the most common reason for death in type 2 diabetes is cardiovascular events. So, unlike the old days, we are looking at the numbers of sugar reduction, glycemic control. We must look at the cardiovascular risk reduction, where now almost all the newer drugs, when they are coming into market, they must say what is the cardiovascular risk, whether it is reducing, at least if it is neutral, okay, not increasing the cardiovascular risk, because we need to address this increased cardiovascular risk in diabetic patients. So how are we going to address it? When we look at the guidelines, to look at how we are going to look at the risk and how we are going to achieve it, looking at the targets or the goals, different guidelines give different set points, risk assessments, and different goals. So if you look at NICE, they give Q risk assessment, that is one of the cardiovascular risk assessment, and in type 2 diabetes, and goal with 40% reduction in LDL cholesterol. But if you look at FDA, they don't talk about the initial lipid level, but they talk about all patients with a different age cutoff with lipid targets, level of LDL reduction. Okay? And if you look at the European guidelines, they go by different risk scoring system, and they talk about risk categorization and target LDL cholesterol levels. Okay? So how about Sri Lanka? We have Dyslipidemia Management Guideline published in 2021 by the Ministry of Health, where it recommends WHO risk prediction chart. I'm sure you have seen this chart. I will come into that, this one. So you can see in the BNF as well. So this is WHO risk prediction chart, where there are different categories where you look at this, whether it is diabetic or non-diabetic, and then whether what is the cholesterol level, whether you are a smoker or non-smoker, and a male, female, and the blood pressure. So depending on that, I try to plot this. Our patients' cardiovascular risk is come to around 6 to 7%, depending on the blood pressure. And there are this calculator is available online. You can just Google it, and you can put in your risk parameters, and you will get the risk. It comes as 6%. Okay, so this is our cardiovascular risk calculator that is recommended in our guidelines. And these are some of the other risk calculators just for the interest of trainees. There are different risk tools, but they are not, I would say, you need to think individually about the patient. This risk indicator may be a clue, but there are a lot of things that are unmeasured here, I'm sure, and there are evolving things over time, and we don't know whether which one is matching our population exactly. Okay, so I will not go into this. These are cardiovascular risk factors. If you're going to get a diabetic patient, you need to see what are the other risk factors. So how about treatment? Most of the guidelines recommend moderate intensity statin, generally atorvastatin at a dose of 10 to 20 milligrams. So if you follow this line, so this is the cardiovascular risk reduction they recommend, about 40%. This is nice guidelines. But if you don't achieve the targets, I just wanted to highlight about this. The intensity of statin, high intensity with 80 milligrams of atorvastatin reduced the LDL cholesterol level by 55%, whereas a very low dose of atorvastatin with estimate 10 milligrams achieve more than 50%. So we do see a lot of patients coming in with a lot of muscle-related symptoms, and it may be reasonable we can step down on statin and add the non-statin second-line drug, which has a very good reduction in LDL cholesterol as well. Okay, so cannot emphasize about the lifestyle modifications. You can see 3 classes for dietary fat reduction, trans fat reduction, and saturated fat, and then the reduced excess body weight. They all come into play with regards to reduction in overall cardiovascular risk, because we are not just looking at the lipid profile, we need to look at all the other risk factors. Okay, so this third case about 64 years old patient presenting to a cardiology clinic, again type 2 diabetes with a history of cardiovascular event. Now he has got the disease. What you are looking at, the previous patient did not have a disease, so we look at the primary prevention. So we are going to prevent the first episode of heart attack. We are looking at primary prevention. For this patient, it is secondary prevention. There are enough evidence, with very strong evidence, with a lot of studies done with target recommended treatment, target LDL reduction, as well as second line treatment, very well evidence based. Okay, so not to forget about other medication, non-statin medication or non-lipid lowering medications, which will reduce the cardiovascular risk. So if you look at a diabetes management algorithm or any guideline, after metformin, always in the second step they say assess the cardiovascular risk, assess the heart failure, whether the patient is having a renal disease, because as I said, all the drugs that came maybe about last 2 decades, 2-3 decades, they need to prove their cardiovascular benefits. So which were favored actually, which were used widely, were the SGLT2 inhibitors and the GLP-1, which reduce the cardiovascular events, which are irrespective of LDL cholesterol reduction. There are several other mechanisms to reduce the cardiovascular risk. Okay, so the fourth patient, a different patient. Now we have started treatment, now referred by the nephrologist. This is actually a true case that I got. 65 years old patient with diabetes and CKD end-stage renal failure on hemodialysis. He was referred with severe myalgia and elevated creatine kinase. He was on atorvastatin and fenofibrate, and this was his last lipid profile. What you can see here, the triglycerides are high and CK is elevated. So this was the reason for his atorvastatin plus fenofibrate, but which resulted in severe myalgia with high CK. So what are you going to do? So this is from NICE guidelines. They give a nice flow chart, even though you can't see it clearly, but I just wanted to highlight. It depends on several things, how you go, which algorithm, which way you are going to go, depends on several factors. The first thing is you need to assess the muscle symptoms, because sometimes patients can say they have joint pains, here and there pains, because with statin there's something called nocebo effect. Have you heard about it? May not be common with our patients, but in Western world they talk about it a lot, because before starting a statin, their perception of statin is reluctant to start because they know they can get some muscle problems. So when you start the medication, they get muscle symptoms, or even before starting it, you get it. So it's called not placebo. Without giving anything, you can still perceive that this, you can give a placebo telling that this is a statin, the patients will get the symptoms. That means the perception of adverse effects to a medication before even they were started on it. So a lot of people are reluctant to start statin, and then if they're having muscle symptom, most important to see whether it is compatible with myopathy. Myopathy, if they have mainly proximal muscle weakness, pain, which is exacerbated on exercise. This is the classic presentation, but still they can have difficulty in climbing stairs, they can have difficulty in combing, or difficulty in getting up from the chairs. They can present like that. So then you need to see whether the CK levels are elevated. Creatine kinase is congruently elevated with the muscle symptoms, severe muscle symptoms, whether it is significantly high. And then there are cutoff levels. If the levels are very, very high, you need to immediately stop statin, because there is possibly patient is in rhabdomyolysis. CK, they can cause rhabdomyolysis, breakdown of muscles with very high. You can see if the CK is very, very high, it could be breakdown of necrosis of the muscles, resulting in renal damage, significant renal damage. You need to immediately stop and admit the patient and manage for rhabdomyolysis first. But if the levels are between like somewhere around 10, above 10, but not exponentially high, still you need to assess the renal functions and aggressively evaluate and treat. But how about the level of the CK? If the level is less than 4, sometimes you can continue the same dose of statin with monitoring of muscle symptoms, severity, whether it is improving or not, because this mild elevation of CK level is not uncommon in general population, which is mainly seen within initial 3 months of treatment, and usually goes away after about couple of months of treatment. But if the levels are above 4 times, sometimes it's a 5 times upper limit of normal, you need to think about stopping and assessing whether the symptoms are improving, and at the same time CK coming down, to see the statin is the causation of this myositis symptoms as well as biochemical changes. Then after about 2 or 4 weeks, you can reassess the CK levels. If it is normalized, you can allow about 2 weeks and restart. We call it a re-challenge, to see at a very low dose, maybe an alternative statin. We call there are lipophilic and lipophobic statins, where there are some types of statins which are not avidly penetrating to the muscles. for example, rosuvastatin and pravastatin, I think. So commonly what we see is rosuvastatin. We can start a very low dose. Since it is long acting, we can give even every other day, maybe once in 3 days, to see whether it is the patient is getting the symptoms and reassess. So there are, if the patient CK is going up again and then it's a thing like it's points towards it could be statin related, then you need to think about second line treatment. So the second line treatment we discussed mainly the acetamide. We can use it even in isolation, maybe 10 milligram, and there are some studies showing even 20 milligrams in isolation you can use in the event of the statin intolerance. And bempedoic acid, there are some studies, but I think we don't have it here available. So we are left with those options and looking at the other cardiovascular risk factors. Yeah, so this is about the muscles. And how about the liver? Do you want to monitor anything when you are going to start on statin? Yes or no? Anything? Most of the guidelines recommend baseline liver function test assessment, not just because you are looking at the statin related liver problem, but we know the metabolic syndrome, they can anyway have fatty liver and elevation, mild elevation of liver enzymes. This is not a like universal recommendation. This is from NICE. They recommend baseline liver profile, but after statin treatment, it's prudent to assess the liver profile, maybe about 2 to 3 weeks, because the significant elevation, until significant elevation, they become asymptomatic. They can be asymptomatic. So after that, once the lipid targets are met, you don't need to assess the liver functions. You can monitor the lipid profile alone. Okay? So how about liver functions rising? How much you can allow? You can allow up to about 3 times upper limit of normal, and if it is more than that, if it is about initiation, better, like it's most of the time it's recommended not to start on lipid lowering therapy and just assess whether if there are any other causes of lipid abnormality, the liver problem, or reassess the lipid profile and liver test again in 3 months. And then having mild degree of elevation of AST/ALT, particularly less than 3 times upper limit of normal, you don't need to stop. You can monitor the liver functions while continuing statins, or maybe you can convert it to a different form of a low dose statin. Okay. All right. So I think I have about 2 more cases. I think so. This is a 4th case. So the same patient. What happened after stopping statin and monitoring? His triglycerides improved. Statin, fibrate both were stopped, and triglyceride improved with the dietary modifications of course, and the CK level improved. But what you can see here, the LDL cholesterol have gone up. When asking about or inquiring about the dietary history, since the patient, you might remember the patient was having chronic kidney disease, he was having a lot of muscle weakness and wasting, and family members thought he needed a lot of protein, and he has been given about 7-8 eggs per day, and which resulted in this very high LDL cholesterol level, which actually within a couple of weeks after changing this diet improved without anything. Then we saw the baseline LDL cholesterol, which we wanted to target to reduce the cardiovascular risk. Okay. So a different case, not diabetes, not cardiovascular event. A patient, young patient, coming to your clinic, a thyroid clinic with normal TSH, and all the secondary causes were excluded. These are not the actual photos, but just showing you what are these, the trainings. What is this? I think everybody knows. This is xanthelasma. What is going to show here? Yeah, xanthomas. You can see in the tuberous xanthomas in the tendons, Achilles tendon, and the hand. Okay, those are some of the hand. In our complexion, they are not appearing as the usual or classically explained phenotype, but you can feel, I haven't seen in Sri Lanka, but In abroad, you can feel the nodularity if you touch the Achilles tendon area, particularly in patients with homozygous mutations, familial hypercholesterolemia with homozygous. That you have if you have both alleles, which is inherited as autosomal dominant pattern. So if both alleles are transmitted to the next generation, they are homozygous, they can have a severe disease manifestation, whereas what we hear or see as early cardiovascular disease, having heart attack, strokes at the age of 30s, 40s, it's very likely they are having heterozygous mutation, just one allele with continuing their lipid profile, LDL elevation, resulting in early cardiovascular death. Homozygous mutation, they are more severe, presenting at early stages. So there are several criteria that you look at. If you just Google it, you can find it, familial hypercholesterolemia criteria. So what are the things that you can guess, or what you can things that you will you should know whether when to suspect a familial hypercholesterolemia. One thing is genetic mucoectasia. In the absence of that, there are two things. One is the abnormally elevated LDL cholesterol or triglyceride, total cholesterol level. LDL cholesterol above 190 and total cholesterol above 290, plus either one of these, either this cutaneous manifestation, xanthelasma, tendon xanthoma, or a family history of high cardiovascular risk, or early cardiovascular event, or high cholesterol level. Cardiovascular event before 50 is in second degree, that means grandparents or grandchildren, and first degree is less than 60. So if you encounter this, so that's why the family history is important. What age did they get this problem, and do you know their cholesterol levels when they get the problem? So those are important. If you see a patient with this degree of elevation of cholesterol, why is it important? Because they're having very high risk of cardiovascular events very early in life, and this is treatable. This is something that you can treat, and you need to treat aggressively, not just our routine target LDL cholesterol. We need to achieve a very low LDL cholesterol, and even though we don't have genetic testing, what we can recommend is, this is autosomal dominant, we can ask the family members to do their lipid profile. So if they have a high lipid LDL cholesterol at these ranges, it's very likely they are also harboring this mutation. So even without genetic mutation, we can still assess before they develop the disease and treat. It's very, very cost-effective way with just screening and just even lipid profile assessment. So this is about one very, very initial stage of our study that we started, we are planning to start a study on genetic testing on patients with possible familial hypercholesterolemia. The criteria, there are two patient groups, very small number, about 25 from each, this possible familial hypercholesterolemia, as well as increased cardiovascular risk, which increased cardiovascular events less than 50 years without any other risk factors. We are going to see whether they are harboring any genetic mutations. So if you encounter any patients fitting into this criteria, you can refer to our lipid clinic in the pharmacology department, because once the ethics approval is taken, we are planning to do the genetic testing to see what is the pattern that we see in our population. We have only few studies available which check only the LDL receptor mutations. There are several types in this familial hypercholesterolemia, but I think it needs a lot of funding. So we started with, in collaboration with this science faculty genetic unit, where they have the funding to get the primers for a limited number. So if you get patients, you can refer, and we can see what is the pattern we are going to see in our patients. Okay. So this patient, again, not a diabetic patient, not in a NCD clinic, presented to the endocrine clinic. Pictures are not real, but actually referred to an endocrine clinic with Cushingoid features, round faces and thin limbs, and maldistribution of fat, centripetal fat distribution, what we say, and she looks something like this, not the exact pictures, but there is thinning of the legs and hands, particularly loss of fat. But unlike in a Cushing's patient, their muscles were very prominent and they had prominent veins. And they have peculiar facial appearance with lot of fat, loose fat around the facial area and back of the neck, something similar to what we see in Cushing patients, dorsal-cervical fat pad. So all the biochemical screening was normal for Cushing's, but this patient had this lipid profile with high, you can see the triglycerides are moderately high, as well as not very high level of LDL cholesterol, but the HbA1c is elevated. They can have diabetes, dyslipidemia. So there are, the patient was found to be possible lipodystrophy. I just mentioned when you looked at this high triglyceride patient, we need to think about whether this is lipodystrophy. There are different subcategories. There are partial and generalized, where you see whole body affected. There can be partial lipodystrophies which affect only parts of the body, maybe face or the upper part of the body, or it could be again categorized as familial or acquired. And the cardinal things that you can guess whether this is lipodystrophy are, apart from a typical metabolic syndrome patient with insulin resistance, high total cholesterol, triglycerides with low HDL, diabetes, fatty liver, and this characteristic appearance with prominent muscles and prominent veins with loss of fat in the arms, but this fat maldistribution suggesting of a more generalized cause. But if you have a suspicion, even though we don't have genetics, we can suspect, but the thing is, even in the well-established centers, there is hardly limited treatment options available. Leptin-based treatment, even in UK, it was available only in one center. They need to follow strict low-fat diet. Statin and fibrate both can be used in these type of patients, and looking at reduction of overall cardiovascular risk. And the last case. So not all the lipid profiles are concerning with regards to high triglycerides or high LDL. So this patient was actually referred to me by one of my endocrine colleagues because she was worried about the LDL cholesterol. You can see it's staggeringly, significantly low. And this patient was off statin for many months. Still, you can see all the lipid parameters were very low. And she was thinking whether this could be a lipodystrophy because the patient had wasted limbs but did not have this classic appearance. But we don't know whether could be this be a lipodystrophy. And the other things that noted were, even though he looked malnourished more than this lipodystrophy, he looked very malnourished. His proteins were high, total protein and albumin was high, and rest of all the investigations were normal. Hematological evaluation and ultimately revealed this patient had multiple myeloma. So it was interesting to see. So after, when we're looking at and reading about what are the causes of low LDL, apart from the things that we know, the lipid lowering treatment, the weight loss, significant weight loss, acute weight loss can have significant reduction of this LDL. And then, interestingly, it was mentioned hematological malignancies due to unknown reasons, various changes in liver lipoprotein metabolism, they can have low LDL level. So it was very interesting to see a lower LDL cholesterol level, but still we need to think whether this is something that we need to look at from the other aspects, not from that's looking at the causes for high LDL, but as well as looking for an etiology based on a lipid profile. Okay, so I think I have come to the end of the talk. So we talked about a lot of things, a lot of cases and guidelines. It may be confusing, but when I looked, as I recently came across this nice review article in Endocrine Review, A lot of guidelines give different cutoffs and different levels, looking at numbers, looking at LDL cholesterol, looking at cardiovascular risk, a lot of mechanistic things. But this gave a very nice infogram or summary what is actually, I thought, very interesting and nice to end my talk. So when you get a patient with a dyslipidemia, either triglyceride or LDL cholesterol, apart from looking at the clinical features, first you look at the cardiovascular risk and the LDL cholesterol, triglyceride, depending on the direction that we want to look at, the goals that we are going to achieve. And then what we have is these basic parameters, and depending on the cardiovascular risk and availability, if the cardiovascular risk is high, LDL cholesterol is high, we can think about other secondary parameters if available. But this is the most important part: assess and look at the secondary causes and complications. History, looking at examining the patient, looking at the history and other subsidiary investigations to rule out the secondary causes are very important. And very rarely only we can think about genetics. Here you can see high LDL cholesterol, often monogenic. It's more likely to be familial hypercholesterolemia still. If you look at the cutoffs and try to do the genetics, 2 out of 3 patients generally will end up to have this genetic mutation. Whereas high triglycerides, usually polygenic. So it's mainly looking at other risk factors and controlling them. And how do you manage? Again, need to stress secondary causes, optimize the cardiovascular risk, and non-pharmacological management with pharmacological management to achieve our specific goal, whether we are going to reduce the LDL cholesterol, if it is this with high LDL cholesterol, or triglyceride lowering. And there are different pharmacological agents. I did not go into detail, but if you refer to this same article, they give a nice overview. And only at suspicion we can think about further testing. So I thought this is a nice overview. It's not just looking at just numbers and looking at reduction of the LDL or the triglyceride levels. It's mainly risk-based approach, whether we are going in the line of LDL cholesterol reduction or the triglyceride reduction, and what is the target we are going to achieve, and almost always exclude secondary causes. And the other thing is holistic approach. We manage the LDL cholesterol. Now it is in the target. We can't just wipe our hands and go away and say now the patient is fine. It's not just drug. We need to think about the overall cardiovascular risk. And the other thing is not to forget, I think we have all the guidelines how to start, how to target, but I don't know whether we have enough guidance or any recommendation how frequently we need to check, what is the interval. Even in the Western world, so they have only unit-based recommendations. There is no universal recommendations, and that depends on individual patients, that we need to think about different risk categories, different the triglycerides or LDL cholesterol that we are going to target. So with that, I think this is about the lipid clinic that we have in the pharmacology department at Peradeniya. So if you have any patients that are interesting, maybe we can try to help and see. Mainly this was initiated to have a patient cohort to see, drive and see what are the things that we see in our patients with regards to different lipid problems. So we have done, actually I haven't included here, we have assessed the cardiovascular risk in university students, assessing about 1,300 students, and we were amazed to see about 10% had pre-diabetes, and significant amount had LDL cholesterol. Nearly about 6%, 6 to 10% have LDL cholesterol more than 160. And there are some subsidiary things that I will will circulate among the medical students. We plan to see what to know there is, because this can go unnoticed until about maybe 10-20 years, and if you don't look at it, if you don't try to adjust it, we would see this polygenic hypercholesterolemia, polygenic problems giving early cardiovascular events. So it's a very cost effective if we can approach to a kind of primary prevention approach, at least to see high risk group. And there are guidelines, but I think it's a problem with the implementation and continuation. Okay, I think I've come to the end of my talk and would like to answer any questions if you have or any comments.